Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
So hello, and thanks for joining me in our discussion about integrating emerging therapies into clinical practice for pediatric ITP, exploring evidence, guidelines, and best practice. My name is Dr. Cindy Neunert. I am in the Division of Pediatric Hematology at Columbia University Irving Medical Center in New York. My disclosures are shown here. So our learning objectives for this talk are to describe the underlying mechanisms and pathophysiology of pediatric ITP, be able to differentiate between pediatric ITP and other causes of thrombocytopenia. We'll discuss the mechanisms of action of some novel therapies, particularly the TPORAs, and then we'll analyze the efficacy and safety and data of these emerging therapies and really talk about how to integrate TPORAs and other treatments into clinical practice, tailoring our treatment plans to individual patient needs. And then we'll discuss a little bit of how to monitor and manage any of the potential side effects of some of these treatments. So as a more global overview, we're going to begin with some modules. The first module is really understanding pediatric ITP. We'll then discuss the diagnosis and how to distinguish ITP. And then we'll discuss the emerging therapies and end with some time for questions and discussion as needed. So let's begin with an overview of our understanding of pediatric ITP. So ITP is defined as an acquired autoimmune isolated thrombocytopenia, defined by a platelet count less than 100,000 in the context of normal white cell counts and a normal hemoglobin. So in this setting, only the platelets should be abnormal. Patients will often present with skin manifestations. These include petechiae or bruising, and these may be the only symptoms. However, other signs of bleeding can be seen. It's just highly variable between patients, the degree of bleeding that they will present with. The physical exam will be normal, other than the signs of bleeding that we just talked about and any other underlying conditions that the patient has. But in particular, we want to make sure that the liver, the spleen, the lymph nodes should not be enlarged. And really, we're going to have a patient that's otherwise very well appearing. We talked about our bleeding manifestations of ITP. These can range, as I said, from mild skin bleeding to more severe life-threatening events such as intracranial hemorrhage. So this is what petechiae look like over here in the first picture. These are the tiny little red dots. We're all familiar with bruises. It's really important to look at the mucosa in the mouth to look for any what we call wet purpura, blood blisters in the mouth, a history of epistaxis, and then GI or GU bleeding. And we'll talk a little bit more about intracranial hemorrhage, but this is really a rare event in children. So when we encounter a patient with thrombocytopenia, we have to sort of start our thought process. So is this ITP or some other form of isolated thrombocytopenia? Do we have to worry about marrow failure or a chronic infection or some sort of inherited thrombocytopenia? What do we need to look at to make that differentiation? If we're pretty certain it's ITP, we may be asking ourselves the question of, is this primary or secondary ITP? Is there an underlying cause, some immune dysregulation or immune deficiency, lymphoproliferation, or again, chronic infection that's the driver behind this? And can treating that driver or fixing that driver actually treat the ITP? So that becomes not only important for diagnosis, but also potentially for our treatment approach. And then we can categorize the ITP based on how long somebody's had it. And this is based on newly diagnosed is from the time of diagnosis to 3 months. Persistent would then be from 3 months to 12 months. And then we really define somebody as having chronic ITP only after they've had the disease for 12 months. So as we mentioned, ITP can be primary or secondary. About 80% of cases will be primary, but you can see here there's a whole host of settings in which ITP can occur, from other autoimmune conditions to other infectious etiologies. And like I mentioned, the ITP may or may not be responsive to treating that underlying condition. We can also see antibodies, transient or long-lasting antibodies in some of these other conditions. So Some patients may be ANA positive despite not having actual clinical condition of lupus. So the fundamental principle of ITP is that this is an autoimmune disorder mediated by autoantibodies. We've talked about different ways to classify it. So we have a couple different ways in which we could talk about a patient with ITP. We could talk about them having primary or secondary, as we just went over. We could talk about how long they've had ITP. Are they newly diagnosed, or perhaps we're looking at a patient with chronic ITP? We can also talk about the classification according to their clinical symptoms. Is this a more mild type of ITP or more severe where they have bleeding symptoms? And there are some terminology papers out there that can help guide us in how to apply these terms to patients. And then there's a term refractory ITP that we will talk a little bit more about, but this is those patients that have ITP that is not responsive to multiple lines of therapy. All of this is really in place, though, just to give us an idea when we're trying to think about a patient, when we're trying to individualize their treatment approach, where are they in their ITP journey? And I think that is what these terms help us do for the most part. So ITP's pathophysiology is rather complex, and I think we're still learning more and more about it every day. But again, the basic principle is really that this is platelet autoantibody production. These platelets, then the antibodies attach to the platelets, they encounter activated macrophages and they undergo phagocytosis. We also do know, though, down here in the lower corner, that the bone marrow of patients with ITP is also affected, and that these autoantibodies are interacting with megakaryocytes in the bone marrow, leading to some degree of decreased platelet production as well. This is actually a better slide that shows us how complex ITP really is. We know the role of autoantibodies. We've known that for a long time now. We appreciate that these autoantibodies are being generated by activated B cells. We also now are appreciating the role of T cells and our Th1 and T17 cells, and the role of the cytokines produced by these cells and the balance that has to be maintained. We understand more about our T regulatory cells, which normally suppress this type of autoimmunity. We've long understood the role of the macrophages in phagocytosis, as I just went over, interacting with these autoantibodies. And then again, there's a host of cytokines and immune signaling that I think we're really starting to tease out, looking at these signals in terms of responses to therapies, chronic versus non-chronic disease, refractory versus non-refractory disease, and really trying to understand if we can use a biomarker or biomarker profile to further classify and further individualize our treatment. So when we think about the epidemiology, there's this peak in the toddler years, which is where us as pediatric hematologists are most focused, but that there is another peak kind of in this adolescent young adult phase, and it tends to favor females in that age range. Overall, our incidence is anywhere from 2 to 6 per 100,000 children. And this is similar to our rates of pediatric ALL. So it does remain a rare condition. It is uncommon, but it is one of the more common things that we might encounter as pediatric hematologists. I like this picture. This shows the differences between pediatric ITP and adult ITP and why it's important to focus on a whole talk just dedicated to pediatric ITP. They're not just small adults. And one of the fundamental differences is this rate of spontaneous remission that's much higher in children, and the fact that they're much more likely to present with this very newly diagnosed self-resolved ITP compared to adults that have much higher rates of chronic ITP. They also have more comorbidities that might affect our treatment decisions, and they're more likely to have other factors that might contribute to higher rates of intracranial hemorrhage. So based on some estimates of clinical studies, registries, and databases, patients with ITP, we mentioned intracranial hemorrhage, but again, this is very, very rare, less than 1% of children, and I'll show you a few studies that support this number. It's really hard to estimate severe bleeding that's not related to intracranial hemorrhage, just because of a lack of standardized case definitions applied across studies, and that are let us kind of cross-compare or combine the data. We do think that perhaps some patients are at higher risk. It is imperfectly related to the platelet count, but usually occurs at less than 10,000. Older age, so the elderly population, age over 60, does seem to be an increased risk factor. And then trauma, or in the setting of other therapies that we know impact platelet function, such as antiplatelet therapy and or anticoagulation, which is affecting a separate pathway. So here's the data specifically on intracranial hemorrhage. The first is from a systematic review of pooled data that shows that the weighted proportion was 0.4% for children. This did look at severe bleeding when defined in the studies, which was very heterogeneous, but was found to be about 20% for children. Data from the Intercontinental ITP Study Group showed that about 0.6% of children with newly diagnosed ITP had intracranial hemorrhage. Severe bleeding, again, occurred in about 3% of children. And then from a last study, ICH occurred in about 1% of children over a 5-year follow-up time period, with about 8% of children having severe bleeding. So again, our rough estimate of less than 1% is probably accurate, and again, just highlights what a rare event this is in children. Because of the fact that the majority of children will have a short duration of disease, and the fact that intracranial hemorrhage is so rare in children, treatment really may not be indicated for asymptomatic patients or those patients with skin manifestations only, so those petechiae and ecchymoses. Treatment may be indicated in patients with bleeding due to some other antiplatelet factor, other hemostatic defect, a trauma event if they have upcoming surgery, any comorbidity that puts them at an increased risk for bleeding, and then other factors about the disease, the patient's lifestyle, and some other factors that we're going to talk about that can be clinical manifestations of ITP beyond bleeding. So the first is really fatigue and depression. Fatigue is a common symptom among patients with ITP, and it tends to not improve over time. About 54% of children and 62% of adolescents in a prospective cohort study reported having moderate to severe fatigue. And there was no correlation between fatigue and age or gender. And it was really not perfectly correlated to the platelet count, and even occurred when the platelet count was only mildly reduced in some patients. The cause is really not well understood, and there may be other contributing factors. So we talked about these associated conditions and comorbidities. And I think we have to be aware of the role of anemia and iron deficiency, particularly in young adolescent women who may experience heavy menstrual bleeding. And I think that's a really important component of the history to take. There's also activity restrictions, and this may inherently just reduce somebody's general overall well-being and lead to fatigue. There's adverse effects of medical therapies, such as sleep disturbances that we know occur with glucocorticoids. Perhaps older age, higher stress levels. We don't know about the role of sort of autonomic dysfunction and the role of these pro-inflammatory cytokines. And I think these are things that people are really looking at to try to better understand why fatigue occurs in patients with ITP. But it likely may also be that it's something multifactorial and individual to each patient. So I think fatigue fits into a more global aspect, and we mentioned lifestyle and fatigue, and all of this is really about quality of life. And we do have ways to perform quality of life assessments on patients. And this is really critical. I think this is a well-established method for evaluating the total impact of the disease and burden on a patient, and it lets us look at that balance between the disease and the treatment and where we fit in that balance with an individual patient. For this in pediatrics, we have the Kids ITP tool, or the KIT. This is a specific health-related quality of life questionnaire for ITP, and it allows for both older children and the parent to do an assessment. For younger children, it's a parent proxy. It is used to support our clinical decision-making beyond just the platelet count and bleeding. I kind of always say to families, the first thing we're going to talk about are the bleeding symptoms. Is there some bleeding symptom that absolutely needs to be controlled right now The second is, what does it look like living with ITP? And then last, we will circle back to the platelet count and talk about that in the context of these other two things. And there really is a push now to get these patient-related outcomes or PROs into clinical trials as reported outcomes. So again, we know that ITP is more than just a platelet count and bleeding symptoms. We know that it leads to children missing school, the expense of care, the toll of receiving treatment, the concern about the increased risk of bleeding, the reduction in quality of life. We know that there's fatigue that patients experience. There's a lot of anxiety around, am I able to do activities? Am I going to be able to go? Am I going to be able to travel? Am I going to be able to do the things that I used to do? Is the family going to be able to do those things? Is there going to be a bleeding event? And where are we going to be when that occurs? And again, this notion of activity restrictions and limitations that I think we as providers and physicians can really be very mindful in those restrictions, and are they necessary at the current platelet count, and how do we balance letting the patient have the quality of life that they need within the context of a safe platelet count for that quality of life. We've talked a lot about this notion of fear of bleeding events and the general fatigue. There's significant data that this is a real component. And we know that quality of life, at least in adult patients with ITP, is similar to or worse than that of patients with other chronic conditions, such as arthritis or diabetes. So this really is a component of ITP that needs attention and that we should be spending time on in every visit we have with a patient. So we know that this is well described. We know it's likely multifactorial. We know that why the fatigue is occurring is really elusive and not real clear to us. And we know that these are the things that can lead to that impact on quality of life. I think, unfortunately, we don't focus enough on it, and it's really hard because I think people don't feel empowered to then know what to do to address it. But for the most part, I think a lot of focus has continued to be on addressing low platelet counts and the best approach to manage the bleeding or the fear of bleeding, and focused on a platelet count. But for many patients, the focus solely on that ignores a lot of their other experience of living with ITP. Patients are often focused on ways in which ITP negatively affects their lives, how they feel and how they function. Fatigue may be the most debilitating aspect of ITP for some patients. And so we have to make sure that, again, when we talk about tailoring our therapy, we're really listening to what the patient is most concerned about. Patients tend to believe that the fatigue and severity correlates with decreased platelet counts. This isn't always the case, but we do have patients that tell us, I knew my platelets were low just because of how my body felt, not because of any particular bleeding symptom. We need to consider these things at every patient visit, listen to the patients and talk to them about their patient experience. And that depending on the extent of how these things are related to the platelet count, we may need to adjust our treatment or adjust our therapy to really reduce that burden on quality of life. And although our therapies may improve the fatigue, other fatigue-directed strategies may also need to be considered. And we may need to integrate a lot of treatment recommendations around fatigue, around sleep hygiene, around exercise and healthy lifestyles into a visit with a patient with ITP. So what's our long-term outcome? We talked about the fact that in children, most of them will not progress to chronic ITP, that's more seen in adult patients. There are a few risk factors for chronicity, though. Older age diagnosis, so once we get into that more adolescent area, we start to think about a higher risk of chronic disease. Somebody who has a more indolent onset, so rather than this very abrupt presentation of ITP, but somebody who kind of incidentally is picked up with a platelet count of 25,000 or 30,000. So again, that higher diagnosis that higher platelet count at diagnosis. Female gender or other autoimmune markers, so the ANA positive patient is more likely. And then if somebody doesn't respond within the first 3 months, that may or may not also then lead to kind of a thought process that that's a patient that's going to then go on to become chronic. although we do know that a lot of patients will still demonstrate a spontaneous remission or a treatment-related remission within within the time frame of that persistent ITP as well. Of those patients that had what was defined as chronic refractory ITP, so failing greater than 3 second-line treatments. So now we're talking about a really selected group. Of that group of patients, there were about 80 of them, 79. Older age was associated with having refractory chronic ITP. So again, consistent just with having chronic ITP. The remission rate 2 years after diagnosis was 9% in this group. So this does perhaps recognize a group of patients that are much more likely to have a longer course of ITP. And they were also at increased risk of these immune pathologic manifestations. So having other immune disorders later on, or being antibody positive for other conditions, or even having a medical condition like lupus later on in the course of their ITP. In a multivariate analysis of a larger group of patients, age at ITP diagnosis, sex, and the presence of immune pathologic manifestations on chronic ITP outcomes, adolescents had a 2 to 4-fold higher risk of bleeding, second-line therapy use, and the presence of these IMs and a lupus diagnosis. And female gender and having a biologic IM were independently associated with a higher risk of having true clinical manifestations or another autoimmune disorder later on. Second-line treatment use, again, the diagnosis of lupus. So I think what this story tells us is that for the majority of children with ITP, ITP is going to be a short-lived, isolated condition, but there is a population that still experiences chronic disease, refractory disease, and those patients really merit close evaluation for development of these other autoimmune conditions. So it really is still a disease that, while we're focused on the ITP piece, we still over time have to continuously ask ourselves, do I think this patient still just has primary ITP, or are they perhaps evolving into some condition of a secondary ITP picture? So we need to continually, regularly follow these children up, looking at platelet counts. How frequently we do that may be based on lifestyle or treatment modifications. It really is individualized. There has to be ongoing assessment of both bleeding symptoms and health-related quality of life. It's really critically important to continuously loop back to this at every visit. Talking about our treatment-related side effects, what we never want is for the treatment to become worse than the disease itself. And again, we just talked about, is this an evolving, or is there some alternative diagnosis if this clinical course becomes a little bit more atypical? Or, when was the last time I sent perhaps screening labs and things of that nature? And then I think we have to constantly adjust our therapy as we move along the patient journey. So let's switch gears a little bit into module 2 now and talk about our diagnosing of ITP and distinguishing it from other conditions. So now that we have a better understanding of ITP, we talked about at the beginning that this is really a differential of a diagnosis of exclusion when we're encountering a child with thrombocytopenia. It is based on physical exam and history and blood work. What we're really looking for is a CBC with isolated thrombocytopenia and a peripheral blood smear that is otherwise normal, with the exception of normal to perhaps large size platelets. We can also look at what's called the immature platelet fraction, and this shows us new platelet formation. So this can give us a sign that if the IPF is high, that gives us some reassurance that we're dealing with a state of platelet turnover as opposed to poor production. ITP can be preceded by a viral infection, so sometimes that's a helpful clue. What we really don't want is it should not present with any signs of organomegaly, lymphadenopathy, any dysmorphic features that would make you think of an inherited platelet condition. So this really, again, diagnosis of exclusion, isolated thrombocytopenia with an otherwise normal history and physical exam. We talked about the various other autoimmune diseases. So if somebody has symptoms for those, it's important to screen for those. And if we have patients with bleeding, they may be anemic. It's our job to kind of ask the question, is this anemia kind of in proportion to the bleeding symptoms that the patient is telling me they're having? So here's our column of supportive symptoms. So again, abrupt onset, a recent infection or a vaccination, particularly the MMR vaccine is the only vaccine that's been shown to be linked to ITP. Isolated thrombocytopenia, otherwise normal. Previously normal platelet counts in the past, if we can obtain them. And this high IPF and as well a high mean platelet volume can indicate these new young platelets being made. We want to make sure that there are no constitutional symptoms, no other ongoing use of medications that could be contributing, no family history of anything suggestive of an underlying inherited platelet disorder. And that includes a screening for things like renal failure or deafness that can run along with certain inherited platelet disorders, or family history of leukemia. Do they have anything else that makes us think we need to be screening for secondary ITP? And then, of course, any other red cell or white cell abnormalities. And then also looking at the blood smear, are the platelets giant platelets, over 50% that we see larger than a red blood cell, or are they very, very small, which might make us think of things like Wiskott-Aldrich in the setting of a microthrombocytopenia? So here's our basic evaluation that we just talked about. You can see here there's lots of other perhaps supporting initial evaluation that we can do, some that are of potential value and some that really have no proven value. And really, this is where we start with every patient is right here. And this is supported by guidelines. So the ASH guidelines really just suggest a CBC and a review of the blood smear in children. HIV and HCV are really only for adult patients. And then further testing really depends on history, and a bone marrow is not necessary. This is also over here showing the recommendations of the International Consensus Report, again showing infectious studies for mostly adults. And then a role of a DAT and quantitative immunoglobulins, particularly, I think this is really critically important in children before they're going to get IVIG, which can then skew those results. ANAs perhaps of screening value in older patients. So I think we really could do a better job at getting a little bit more uniform, but I do think we have this core component of it remains a diagnosis of exclusion based on the peripheral blood film and the CBC, history and physical exam. This is one flow diagram of how to approach the patient with thrombocytopenia, ultimately getting to a diagnosis over here on the right of ITP. So starting with thrombocytopenia, of making sure that it's true thrombocytopenia, thinking about smear clue, peripheral blood smear clues, that it's not a hereditary thrombocytopenia. And then really this is looking a lot at our red cell and white cell morphology to make sure we don't have any other clues that we're not dealing with ITP. Once we're in the category of isolated thrombocytopenia, then we can start to work through our diagnosis of an ITP, whether or not it's primary or secondary. This is another more pediatric-based flow sheet. Again, really first confirming on our CBC and our peripheral blood smear that we don't have platelet clumping and that we don't have other signs that we're dealing with a dysfunctional marrow. And then we come down here, and this is really to help us distinguish as well the fact that we want to make sure that we're not missing an inherited platelet disorder. These are going to be patients that present with a perhaps prior low platelet count, more moderate thrombocytopenia, some family history of thrombocytopenia, really uniformly large platelets, again, a very, very high IPF or abnormal platelet granulation, and then neutrophil inclusions. Those would be some clues. And for that, you can go either to flow cytometry or genetic testing. Thinking about things in terms of microangiopathic hemolytic anemias based on red cell morphology. If we have findings of splenomegaly, we want to think about hypersplenism or liver disease. Drug-induced thrombocytopenia, we talked about medications. And then over here again on the right, we ultimately get down to our diagnosis of thrombocytopenia or immune ITP. And again, then trying to distinguish is it primary or secondary. And ultimately, if we have concerns for some sort of underlying inborn error of immunity, we may again ultimately end up with genetic testing. So here's just again walking through primary and secondary, as that's been kind of a focus of some of what we've talked about. But again, I think really the distinction is that primary ITP most likely to be more short-lived and resolve, whereas secondary often will be more of a chronic course. And I think the main thing to note here is that, as we talked about before, this could be an evolving picture. So it's something we need to come back to on our patients regularly to reassess them. We talked about inborn errors of immunity on the last flow sheet slide. So we want to screen for inborn errors of immunity. So this might be the child who's younger than age 6 months, has some longer standing history of easy bruising or bleeding symptoms, disproportionate bleeding to the platelet count, a history of chronic infections or some other finding, failure to thrive, poor growth, family members with thrombocytopenia. These can either be autosomal dominant conditions or X-linked for the most part. We're looking again, we want that elevated MPV that's really, really high or a markedly high IPF in either direction. Those should maybe be a red flag. And then on physical, for the inborn errors of immunity, we're looking for syndromic features. And on history, we're also looking for any other signs of chronic illness, such as diarrhea, pulmonary disease, anything else that might lead us to an alternate diagnosis. What about leukemia or marrow failure? In the pediatric oncology group, and this is why we really no longer say that patients with ITP require a bone marrow, pediatric oncology group did show that of 2,000 children with ALL, none presented with isolated thrombocytopenia. That doesn't mean that there weren't subtle other changes, such as a slight increase in MCV or mild splenomegaly present. But in the pediatric oncology group, 2,000 children with ALL, none presented with isolated thrombocytopenia. So it's our job to really be thorough in that assessment and confirming isolated thrombocytopenia. Here's just some other markers. Again, we've spent a lot of time talking about the absence of lymphadenopathy and hepatosplenomegaly. Leukemia can present with bone pain. And then again, anemia, we need to assess if it's proportional to bleeding or seems out of proportion, and isolated thrombocytopenia versus other findings. There is also some data on thrombopoietin levels, where thrombopoietin levels will be normal in signs of platelet turnover, and they will be elevated in conditions where it's due to hypoproliferation, such as aplastic anemia. So I like this summary slide. This just summarizes our red flags. So here's our red flags. We've talked about each of these more specifically on the other slide, but just to summarize, any of these signs really warrant further investigation to rule out other conditions. And so this really is truly the pathway that we have to work through. So once we've really confirmed that somebody has the diagnosis of ITP and we have to start thinking about treating them, our treatment landscape is definitely evolving, and we're going to spend the next bit of time talking about some emerging therapies. So ITP is not a simple disease, as I just showed you. It's common to have it be heterogeneic. It's accelerated platelet destruction, but also impaired production. Many treatments are available now, allowing for a wider range of choices. Individual patients have different needs, as we've talked about, and treatment choices are complex in the absence of real biomarkers and randomized trials to help guide us. And we also can't really offer patients at the moment what we would consider truly curative therapies. So before we talk about what we're going to treat somebody with, we need to be thoughtful about why. So what are our goals of treatment? Are we trying to maintain a safe platelet count? But we need to balance that with minimal toxicity. So again, when we think about the toxicity of therapies, this is really significant, and it actually really impacts patients. When we talk to adult patients who have been on chronic courses of long steroids, they find that that treatment is actually worse than what they would be worried about in terms of bleeding. We should individualize our therapy based on bleeding risk. We don't really have good markers for bleeding, but I do think in a patient who has had a past history of bleeding, we need to be a little bit more thoughtful in what platelet count we want to maintain for that patient. And certain treatments may be acceptable for longer periods of time based on efficacy and tolerability. There are several published guidelines, and while helpful, they don't overcome the lack of biomarkers or comparative trials that we just talked about. And there's really a limited number of randomized controlled trials in ITP across the board for adults and children. And really, when there are randomized trials, they're normally comparing just a drug to placebo, not side-by-side comparisons. And we do have some placebo-driven studies here for some of the drugs that we'll talk about. So here's, again, an expanded view of some of our treatment goals. And I think each of these is individualized. And we should be clear in our goals with each patient, and make sure that it's not just what I think is the right goal for a patient, but what a family tells me are also their goals. And then we integrate that and we come back to that every visit to say, are we addressing these goals? Here's the goals that we said we were going to try to achieve by being on therapy. Now, have we done that? And is there something new that's come up that we haven't addressed or that we need to think about, or some component of being on the therapy that's now leading to another thing that we need to address? So this is coming back to our pathophysiology slide, and now we have specific treatments. We can tackle the idea of these antibodies. We can work on producing platelets from the bone marrow, and then we can also sort of dampen this activated immune system. In principle, our first step is to decide when treatment is needed, when can we withhold treatment, when is observation a reasonable approach. We always want to use the least toxic treatment at the lowest dose, and this is why long-term steroids are avoided in children and short courses are what's recommended. We may at times need to think about combination therapy, particularly in an emergency situation. And I think we're trying to understand if earlier use of second-line therapies results in any more durable platelet count response or benefits. There's been adult trials looking at upfront use of combinations of rituximab or the TPO receptors, and I'll show you a little bit of data from a recent study in children. So our initial treatment options, we're not going to spend a lot of time on in this talk, but just to remind everybody, include short courses of corticosteroids. Prednisone is preferred in children. Dexamethasone is not really recommended, but is used in adults. IVIG, and then IV anti-D immunoglobulin. Where we're going to focus is mostly on our second-line treatments shown here. I'm not going to speak about fostamatinib as it's not approved for children and likely will not be because of bone development. So here's our second-line treatment options that we're typically considering in children. We have our TPO receptor agonists. We'll talk about each of these more specifically: rituximab, splenectomy, and then a host of other immune modulators that have been used, including MMF and 6MP. We do have other treatment options also shown here. And then I just want to highlight, there's a lot of exciting information coming out about truly novel emerging therapies. Many of these trials are ongoing in adults with ITP and are extending down into teenagers, and we hope will actually reach the pediatric population. So I think that it's just exciting to see all of the ongoing trials. These are all drugs that are currently under clinical investigation. We have two settings in which we're thinking about using therapies. We have these emergent treatments, and this is really where I think about that first line category that we talked about. This is really when we're trying to increase the platelet count rapidly, and we have active bleeding that we're trying to control. But then we want to start thinking about disease modifying therapies. What can we do to address all these goals? Is there anything that we can learn about the biology of the disease or how these drugs work, that they might be more disease modifying and people may be able to come off these drugs at some point? And this is where we're really trying to use pharmacological agents to achieve and sustain a durable maintenance response in the platelet count, and prevent those exacerbations and overall improve a patient's quality of life. What platelet count is adequate really is individualized, and we have to, again, balance this adequate platelet count and achieving that goal against treatment side effects. So it's always this very delicate balance, and it may change over time. So again, all of these are things we need to be coming back to with each patient at our visits. Short term, again, emergent therapy, let's stop that bleeding if we have it, or maybe we're trying to prepare for a surgery or some risk of trauma. Long term, though, what we're trying to do is find the best drug with the lowest side effect profile to get us to achieve the goals that we have set. So when we look at our guidelines, we do have some guidance on this, and I will just say that across both of the widely used guidelines and consensus documents, really the recommendation for second-line therapy in children is to approach first with the use of one of the TPORAs, then consider rituximab, and then really reserve splenectomy for the rare child that is not responsive, should be delayed until age 5 or greater than 1 year of onset. It does still remain, though, good therapy in the emergency setting for the child that has the rare intracranial hemorrhage. So I don't want to say that splenectomy is never an appropriate therapy, but we just really want to be selective in our use of it. ASH guidelines really didn't talk about MMF, but the consensus document said it could be considered or used in combination with the TPO. Neither talked really about sirolimus, although there is some data that perhaps sirolimus is a good option. Azathioprine and 6-MP have been mentioned, but are really reserved for children failing other therapies. Azathioprine does remain a good choice in pregnant patients, so in that setting, it may be used. Hydroxychloroquine, not mentioned in either, but we're learning a little bit more about the role of hydroxychloroquine, particularly in perhaps those adolescent patients that have a positive ANA. So if we think about our individualized treatments, here's all the things that we've talked about. This is in the context of going back to that first module where we really got into the burden of the disease. And as we're setting these goals, we're talking to ourselves to say, okay, do we need treatment to address that goal? And this is, the things that are mentioned in the consensus guideline of all the things that need to be taken into consideration. Many of our relative factors are things that we're already assessing, but it's really good to engage in meaningful conversation with our patients. And again, just shown here, all the things that we're trying to balance. So once we decide on treatment, if we're going to go with those recommendations of a TPORA up front as our first second-line therapy, we have 3. We have romiplostim, L-thrombopag, and avathrombopag. The main difference is that romiplostim is a sub-Q injection once a week, where L-thrombopag and avathrombopag are oral medications. L-thrombopag does have food interactions, which the other two do not, and it also is associated with hepatotoxicity, which needs to be monitored, as well as does have evidence of being an iron chelator, so we also have to monitor iron status. These 3 are all approved by the FDA. We don't really use lisothromopag, and it's mostly used in chronic liver disease. This, to me, which one we choose really, again, comes down to some degree of patient preference. It's important to note, though, that they all are binding to different sites on the receptor. So if a patient doesn't respond to one, we can try to cycle them on a different one to see if a different one might work. So here's the romiplostim data in children. This is just showing a platelet count greater than 50 for 2 consecutive weeks. And you can see here, this was achieved for the most part in about 80% of children. If we look at overall platelet count response compared to placebo, you see this was much more likely to occur in patients receiving romiplostim than placebo. Here's some L-thrombopag data. This is pooled data, just showing that overall the data favor L-thrombopag over placebo. And here's more specifics on that data. So this is from the Petite and Petite 2 pediatric studies, showing a comparison in platelet response and sustained response of 60 versus 32%, and then 36 versus 0, as well as 75 versus 21 and 41% sustained versus 3%. In addition, fewer patients required rescue therapy. Majority were able to discontinue or come off other therapies, and bleeding events were reduced. This is some real-world data from a pediatric cohort of patients that received either romiplostim or L-thrombopag. A consecutive response was seen in about 70% of patients, equal between the two drugs, as well as just a one-time response similar to the data presented earlier of 80%, again, similar between the two drugs. There was then a look at just a mapping of the platelet count to see how many patients just had a nice stable platelet count over the duration of treatment, how many had kind of an intermittent treatment where the platelet count was up and down, how many patients started with a response and then it waned off, and then who truly had no response. There was also a category of other. This included patients that maybe stopped the drug or were deemed to be non-adherent with therapy. So you can see here this nice stable platelet count occurred in about 40% of patients, with then a handful having this up down and a small amount having a response that then tapered off. And no response was seen in about 13% of patients. So it's a very, very small group. I think the other is also really important to look at. This is the group where they just either stopped, it was not tolerable, there was non-adherence. And you can see here 12% of patients with romaplostin, which does require a weekly sub-Q injection, and 33% of patients getting althrombopag, which is an oral daily medication with diet restrictions. So this is the PINES trial. This is now looking at althrombopag up front. I said that this has been done in adults, but now here's some pediatric data. So the inclusion criteria were shown here. This was children newly diagnosed requiring treatment. It could either be upfront treatment, meaning they were treatment naive, or it could be that they've failed one prior treatment, and then they got randomized 2-to-1 to either receive althrombopag or standard of care at the investigator's choice. So these were patients that still require treatment, and they could get either IVIG, steroids, or anti-D. This decision would be made by the treating investigator. And then platelet counts were assessed at 6, 8, 10, and 12 weeks. And the primary endpoint was looking at greater than 3 or 4 platelet counts over 50 during weeks 6 through 12 without the need for rescue therapy. So really trying to define a true response, eliminating anybody who then received rescue therapy. Patients were then followed for a whole year. This shows our interim analysis, but here's our total enrolled cohort here. Looking at althrombopag, you can see much higher rates of responders, above 60% compared to placebo, compared to our standard of care group, which had a much higher rate of non-responders shown here. So now we'll talk about avathrombopag in children with ITP. This is some new data that from the pediatric trials, and looking at their efficacy endpoints, you can see here that a durable platelet response was seen in 30% of children compared to 0 who got placebo. Looking at a different cutoff and a different time point, 80% of patients compared to 0. And here's again some different secondary efficacy endpoints, but really the message here is that no matter how we define the efficacy endpoint, it was very, very low in the placebo group and much better with the use of avathrombopag. And so I think this is really exciting data to see come out on avathrombopag in children. And hopefully we'll have this available in clinical practice shortly. And I think we can all feel comfortable using it based on the data that we've been provided. This was looking at secondary rescue therapy, again, reduced, as well as reduction in bleeding symptoms. So similar to what we know about romaplostin and althrombopag, but it gives us another option. It gives us another oral option and one that doesn't have the same dietary restrictions and may just be a little bit easier. Again, I think which one we choose is going to be patient preference. And I think it's important to remember we can kind of move patients between therapies depending on response. So we've talked a lot about this patient journey. We've talked about how patients present with symptoms. It might be to an emergency room. They get the initial diagnosis and it's confirmed. And then we enter into this process of shared decision-making where we provide education, we exchange information. We're really trying to take our clinical experience, our clinical context, and match that with a patient's experience and context and come up with an evidence-based patient experience-driven treatment. And this is an iterative process. We're going to revisit this every time we see that patient. We do know that this is important to patients. We do know that when we looked at parental or patient reasons for selecting a second-line therapy in a cohort of children, parental or parent preference was involved in decision-making in 55% of cases. 18% of time, it was the number one selected reason for choosing a particular agent. This is in comparison to reliance on these published guidelines that we talked about, which was only really endorsed in 9% of cases. So again, guidelines are out there. They give us the foundation, but it's this shared decision-making, individualized treatment that's really leading to selection of therapy. So in conclusion, ITP is a heterogeneous and complex disease involving both increased platelet destruction and impaired production. Diagnosis and management requires an individualized patient-centered approach due to variability in presentation, treatment response, and patient goals. Multiple strategies exist, and each has a distinct benefit as well as distinct side effects and limitations that we need to be aware of. We're still learning more about the role of earlier upfront treatment, and it's promising, but it remains uncertain. But with shared decision-making, we may guide this therapy. And I think it's really exciting to see some of this data come out in pediatrics about kind of this earlier use of the TPORAs as we presented. And treatment decisions can be challenging. We lack our biomarkers, we lack randomized comparative data, and we need to align with patient goals and tolerance. And, this is the fun part of getting to practice the art of medicine and really engage with our patients. So I'll conclude this talk now, and it's really been a pleasure. Here is our credit. Please go back to the expert insights on ITP at Practice Point CME, and you can claim your credit for this. And also look at other presentations of interest. And you can also download the mobile app. So thank you for your time and attention today.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practicepointcme.com to complete the post-test and evaluation to receive continuing education credit.